Good morning and welcome to this, the third in our series of debates. Firstly, I'd like to introduce Stephen Gaduzo. Stephen is a Stockport-based GPSI and is currently also chair of PCRS UK. And welcome too to Mike Morgan, based in Leicester. Amongst many other things, Mike is a consultant respiratory physician, NHS England's Respiratory Clinical Director, and editorial chair of Respiratory Futures. Over to you both.
Morning. Good morning, everyone, and thank you, Aileen, for that kind introduction. I'm just going to start off with a few slides just to set the scene. My colleague Stephen will butt in if he feels he needs to, but there will be a list of issues that we're going to have a conversation about towards the end of the slides. This is the third webinar, as Aileen has pointed out, but it is the very first conversational one that we've had, so there may be some excitement, or on the other hand, it may not go as well as we expect, but let's have a go anyway. So what we're going to do this morning is have a conversation between a general practitioner, albeit one with an interest in respiratory disease, and a hospital specialist, because it's evident that whatever happens in future, we are going to need to bridge the gap between the GP and the hospital specialist. I just want to set the scene so that we understand where all this fits with our health service. In England, well, and the UK in general, we have a gatekeeper system or role for general practitioners. That is, that if a patient has a problem, they go first to their general practitioner and then will be referred, if necessary, to a specialist, a hospital specialist in this case. Not all countries in Europe have this system, and it's possible in many countries that a patient can go directly to a specialist without troubling the general practitioner. Now, the advantages of having this gateway system are twofold. Firstly, it provides value for money in that it sorts out those who don't need to go to a specialist. And secondly, it protects against over-investigation or imprudent medicine. So it's a system that we're used to having. But some people would be critical around Europe and say that one of the reasons that we don't have particularly good results in comparison is because patients don't have good access to specialist care. Now, it's evident in England that we do have a barrier between general practice and specialist care, and there are several reasons for that. GPs work in primary care in the community, obviously, and specialists are confined to working in acute trusts by and large, though there has been some recent development around integrated care physicians, particularly in areas like diabetes, less so in respiratory medicine. But if you try to think about what those barriers would be, some of them will be structural or geographical, that the acute trust is just not convenient for patients to attend or difficult to get to, maybe quite long distances in some part of the country. There are clearly commercial barriers in that general practices and acute trusts operate completely different business models. And you may think that there are some professional barriers too, that specialists don't deign to go and deal with their GP colleagues, or GPs might feel that they have all the skills necessary themselves. The latter, I think, is certainly not true, certainly not in respiratory medicine, where the professional society, the British Thoracic Society, has been very positive about integrated working. Now, we're entering a phase in the NHS in England where we're exploring as a necessity, new models of care, and these are going to involve greater devolution, more co-commissioning, working with CCGs and primary care organisations, and particularly the encouragement of new models of care. And I'm just going to describe briefly how these might affect general practice and also acute trusts. If you think about what is likely to happen to general practice under this new direction, there will inevitably be more investment. This is sorely needed. GPs are under strain, there aren't enough of them, and the overall cost of the health service is very much biased towards secondary care. But to counter that, we'll have to move away from individual small practices, and that's already started, if you like, through the generation of natural federations of GPs, but this will become more formal perhaps with the development of these new multi-specialty community providers. These are practice is enlarging to include a lot of other ancillary services, hospital consultants coming to visit, and other diagnostic services which they don't currently do.
So, Mike, I think it's important to say there that you're not just talking about changes in the way that secondary care and the traditional model of hospital care develops in the future, but that's also a big change for many areas of primary care. There's still quite a lot of small practices, even single-handers, for whom life is increasingly difficult, and that model of one GP providing all services for all their group of registered patients is really quite difficult to sustain, and the sort of more specialist provision in the community is something that general practice is aware of and is moving towards, in terms of, as you say, not just groups but now federations, etc., which are going to be more involved in the commissioning of services with CCGs.
Yeah, I think it's a direction that everybody needs to go in. I mean, the old model of the single-handed, isolated GP just is not practical anymore. Patients expect something different. So there will be changes, and also I think that the old style of being on call 24/7 as a GP has simply gone out of the window. The workforce has changed. They're not going to provide that. Similarly, if you look at what's likely to happen to acute trusts, I mean, the intention is that they would get smaller. If we have a fixed budget for healthcare and we give more to primary care, then the natural thing is that the hospital budget will shrink. So there will be less investment in secondary care, but hopefully there'll be less emphasis on the urgent care side of things, which currently provides most of the business for acute trusts, and much more focus on elective and specialised care. They will themselves have to work more closely with primary care, and the other model of care provision, which is outlined in the 5-year forward view, is this business of acute trusts developing out towards primary care, starting to employ primary care organisations that feed into the acute trust, and this is called the primary and acute care system.
That might be something that's worth having your thoughts on, actually, questions, because that's quite controversial in some areas.
Yes, though it's something that other countries have developed as a form of vertical integration. And the intention of developing these new models of care is to work towards vertical integration, and I liken it to stalactites and stalagmites, where the packs are working downwards, if you like, from the acute trusts, and the multi-specialty providers are working upwards from primary care, and hopefully this will meet in the middle. As Stephen pointed out earlier, there's a chance that they might not. But
well, stalactites and stalagmites don't always meet, and I think, like a bridge builder, you have to be very aware of where your sort of joining point is going to be, so that you do end up with a properly integrated and not just two silos that never meet. So.
Yeah, and also I think the intention of these things is that there isn't one size that fits all. Yeah. And in one particular geography, one may be dominant and the other one may develop, another one may develop elsewhere. So the sort of topics of conversation which we thought might be of interest today are around these areas that I've listed, around communication, models of specialist provision, particularly issues around standardization of patient information, use of care bundles, early diagnosis tools, because that's a particular problem with respiratory diagnosis. Spirometry is an issue. It's not standardized or accredited at the moment. And we want to look at sort of what resources might be available to promote closer working in anticipation of the new care models. So as the questions come in, I'm not sure how many we've got at the moment, but Stephen already has a few topics that he wants to sort of bring up.
We've got a question from Mike Baldwin, actually. Do you think that there will be different capabilities of the various MSCPs in the future? Say some specialising in elderly care, and where does this leave respiratory capabilities?
Oh, well, who knows? I think if one of the things that has happened has been there is an invitation for vanguard bidders for these care models, and you can find those descriptions on the NHS website. And in fact, the ones that have been successful have tend to compartmentalise things. I look at long-term conditions or elderly care, One or two of them do mention COPD as something that they will develop a particular specialism in, and you can see that one of these MCPs. I'm not terribly keen on the acronym. It reminds me of the 60s a bit. It may well choose to develop particular specialties. They're not obliged to do all of them, but you could see that in one area where the population might be particularly elderly, that might be a focus, or in the next mining area where the respiratory is a focus, they might well want to develop specific skills to their territory. It's all rather fluid, and excitingly so. What do you think, Stephen?
Well, I think there's certainly an interesting aspect there from CCG point of view, because most CCGs have taken needs of the complex patient, and elderly patients would fall into that. The multi-morbid, whole patient-centered approach, as opposed to a specialty-centered approach to a management pathway. But within that, and within models of care for patients with multi-morbidities, there must be room for the best care pathway for the individual conditions that make up the whole picture. And I think that's where our input in respiratory may well lie in the future. If you have a respiratory condition and other conditions, you can't ignore the specialist aspect of it and deal simply with the fact that there are lots of morbidities. You have to individually address them.
That's great. I'm sure Mike will come back to us if he's got a supplementary.
Okay. Well, I'd like to ask Stephen a question, because in the survey that the BTS carried out last year, asking people what they thought was the single most important feature of working with a specialist in primary care, there were many different answers. That may represent, of course, people's working arrangements, but I'd like to ask Stephen, in his practice, if he ruled the world and we had worked in a single organisation, what he would like me to what role would he like a hospital specialist to play in his practice?
I think there are quite a few, as the answers to the question in the survey showed. I think there are some issues that are absolutely crucial. I think common pathways and common resources that give patients a consistent approach and a consistent advice are very important. I think education, both of primary care about secondary care, of secondary care about what goes on in primary care, and if integration is to be truly vertical and include everybody, then the patient should be included in that. And central to all of that must be communication. We use very different systems of recording clinical details and records. Primary care has been largely computerized for most of my 25 years in practice. I've used computer records, and yet in my role as a GP with special interest in the community, now working for the Foundation Trust, everyone's using paper records still. Communication therefore is selective because there's no access to other stuff, and sometimes not just selective but exclusive. So simple stuff like it would help me a great deal to have spirometry readings from hospital appointments coming across to me. Wouldn't it be great if we could all write in the same clinical system, although many billions have been lost in the pursuit of that. And I think there are resources such as what is the best care for a patient with a particular condition, where there's a lot of overlap, and we should be using the same tools and recording the same information and communicating with each other about it.
When we discussed this before the session, we thought that solving the NHS's IT problems was above our pay grade.
Yeah. But
clearly there are little things that you can do to help by transferring important information like spirometry. I wondered, there's a very good example of a new way of working in the diabetes service in Hampshire, where they've rethought how they do diabetes. And one of the services several of the services that the specialist diabetes service offers to their GP colleagues are email and telephone access to have a regular daily surgery available to general practitioners for emailing and telephone access, and also the offer to go and visit the surgery two times a year to either train or teach or go through particular cases. Do you think that's a way forward?
And there are various other models around that. For example, a respiratory interest group doesn't have to be just primary care led with practice nurses, GPs, etc. It could be right across the integrated team, so that the education is not delivered by one sector to the other sector, but it becomes a sharing forum for best practice. In terms of input into direct patient care, there are a few models where there's an in-between stage, if you like, between being reviewed in primary care and being reviewed in secondary care. There are some models which might give us a vision of the future, which are allowing access to community specialist teams, which are more often now integrated with the secondary care teams, who might be the same people who, for example, provide your supported discharge or pulmonary rehab, and therefore that becomes a much more, I hate the word seamless, but there you go, seamless service where the boundaries between what is primary care and what is secondary care are sort of eroded slightly, and what is best care starts to be more.
We still fall into the trap, don't we, of talking about primary care and secondary care as if there's a barrier there, and I don't see it like that really. I mean, I see it, primary care is obviously where those things happen, but then it should be a graded and, as you say, seamless passage to total secondary care management at one end, or specialist management at one end, and then for a minority, and then graded throughout. So
and the recognition of the fact that the word specialist doesn't necessarily have to apply to a hospital,
no, absolutely not,
practitioner, and the word generalist should perhaps increasingly be the forum of a secondary, of what we see as a secondary care practitioner. Is that the patients, for example, don't really look at. They don't really care what you call yourself, do they? As long as you know what you're doing, and as long as you give them the care they need.
That's right, and they should increasingly have a view. I believe we've got one question from a patient, or haven't we? From Malcolm.
We do indeed. One moment, and I'll bring that question straight away. Yes, we had a very interesting question sent to us in advance, thanks to Malcolm Wellens. Community and specialist care is an opportunity for a more integrated approach to healthcare. As a patient with IPF, Malcolm was keen to be able to travel around the country, but many patients can't. They're led by the demands of oxygen therapy and so forth. It's important that they're either treated locally or at home. Specialist commissioning places the focus on diagnosis at specialist centres. What we really need is to find a model where the consultants can visit the patient rather than always demanding the patients visit them. Is that possible? How could the NHS address this strategically and nationally? Stephen?
Right. I suppose the issue of visiting patients at home is a wide issue that includes even acute care and general practice. Obviously, an individual healthcare professional visiting a patient at home takes longer because of the travelling, etc. And when you're at the home, there is less specialist equipment because you're limited to what you can carry with you. Now, some of that can be done very nicely. For example, oxygen assessment teams can carry portable equipment which they can use at home. Spirometry, etc., can be done sometimes at home by the right person with the right training. But in terms of organising care, this is a good example of, patients being asked to fit into systems that exist and have been organised for the convenience or for the ease of patients, of the practitioners, as opposed to trying to sort of design the care around the patient. If you are truly housebound, then there's very little else that you can do other than be visited at home. And how do you find getting a dentist or an optician to visit you at home? Because that's limited too. As far as the specialist visiting at home, Mike?
Yes. Well, I'm an expensive resource, of course, so it's not a terribly good use of my time to go travelling around when you can see a lot more patients in a clinic session. But I think that the point that Malcolm makes there about specialised care is very important, because in unusual or rare conditions, then the purpose of specialised commission is to provide a uniform standard of care for patients, but importantly to provide equality of access independent of geography. So it is not expected that people should necessarily travel to remote centres, but that they should have easier access through their general practitioners or their local secondary care doctors to the same standard. I'd also point out that actually we do operate in a domiciliary service in many circumstances where we would not necessarily send the consultant out, but members of the team will go out and deal with specific technical issues around home ventilation or the like for appropriate patients. So it's a question really that has changed a bit with the time, and I think Tesco's have it right, don't they, where they say that people are prepared to travel for up to 30 minutes, but no more.
And I think that also impacts on the idea of how do you define a specialist. And if a member of the specialist team is visiting for a specific purpose that they carry out at home.
No, that's absolutely right, and people feel in touch with the specialist team whichever member visits or gets in touch.
Vince Max raised the issue of virtual clinics, which are perhaps somewhere between the two. I don't know if either of you got any direct experience of working in that way.
I don't have any experience on them, but I know they work for some people, and whether that's a virtual clinic, i.e. video contact with a patient, or whether it's an MDT video conference with primary care, I think that would work particularly well. I don't have any experience with the direct route with patients, but you can understand in remote or rural situations that would work quite well.
I think while I'd love to have more involvement with really technical stuff, like you're almost describing a Skype clinic, aren't you?
Yeah.
I've got no experience of that at all. In terms of a virtual clinic, there are tools. Sorry, small plug here for Primary Care Respiratory Society. There are tools available that can help you to identify the patients most likely to be in need of acute use of services, so most likely to exacerbate, most likely to admit to hospital. And there are also tools likely to help you to identify patients who may be towards the end of their life with COPD. One virtual clinic which most practices use already is the gold standards framework for palliative care. So our practice and many others use the GSF meeting as a virtual ward round where a brief summary of where the patient is at can be given to the entire practice team, which also includes district nurses, Age UK, etc. The other example that we have a virtual clinic for is the community team that I'm involved with as my role as a GP special interest. We have a similar sort of patients with greater need virtual clinic most weeks, and that keeps everybody abreast of where the patient is at that moment and who's recently admitted to hospital, who's most likely to be the next 6 months. So it's very useful, and there's lots of much more detailed examples. I'm sure Vince has those examples.
And we're getting quite a steady stream of questions. Obviously, we don't want to break the flow of your conversation, so we will answer those online later if we don't answer them on air now. But there have been a couple of questions about striking that balance between using new and creative ways to stretch the already stretched resources effectively, whilst also presumably recognising that sometimes it's incredibly valuable to see a patient in the home setting, and to try and strike that balance must be a continuing challenge. It's almost a yes or no question.
I'm drifting towards a yes.
Yeah. I don't think you would disagree with that, no. But you do have the economics to deal with. Any other questions?
We have a question from Angela. Well, it's a comment really from Angela Scott. Thank you, Angela, who sees virtual clinics as where the case can be reviewed, perhaps without the patient being directly there, but ultimately the care needs to be face-to-face with the patient. So it's probably a very good way of reviewing cases, as you've touched on already. That's fine.
Okay, do we have any others there, or should we
please carry on?
Carry on chatting. Well, on the list of things that we've got, there's a thing around standardisation of patient information, which I believe, Stephen, you feel quite strongly about it.
Yeah, I do. I think we all have resources that we use, and for example, a guided self-management plan, an action plan for exacerbations or worsenings, and information leaflets. And I just wondered how people felt about that. I mean, I feel very strongly that as a patient, you want a consistent message, and you don't want to be getting 3 different messages from 3 different people that you see. So that if you were, for example, in contact with your primary care team, which could also involve more than one individual, if it's your practice nurse, your GP, the GP that specialises in respiratory medicine, and the one that doesn't, a specialist in a hospital clinic who may be a prof like yourself, or maybe a junior, or maybe a gastroenterologist who happens to be the one that admits them, and then the community team who may have supported their discharge. There's a potential for a lot of different people to give different advice, and I think consistency of message is really important. For example, in Stockport, one of the things that we've done, which has been a very big success, although difficult to measure, is that we use the same self-management action plan. GPs, community team, secondary care have the same plan, and it's a patient-held thing that they take away with them. So when you refer to your self-management action plan, the patient knows exactly which one you mean, because there's only one, and that's a great strength.
Yeah, I wouldn't disagree with that. I think I mean, there's so many examples of information out there which is actually self-contradictory, and I think the first step is to be absolutely clear about the nomenclature, because there is a distinction between action plans, self-care advice, self-management training, which requires behaviour change, and perhaps best done in the context of rehabilitation. So we do have to be precise about that, but also that there is a very strong argument for standardisation, and perhaps this is something that the professional organisations and the charities maybe should get together and lead to try and develop some sort of standardised approach to this. So yeah, I'm all in favour of that.
The other thing which I feel should be something we just mentioned is care bundles, because increasingly I'm of the opinion, and not just me, that the kind of basic items involved in a secondary care discharge bundle following admission, a primary care review post-exacerbation, a hospital outpatient review, and a primary care annual review, for example, are pretty much the same basic things. And there you have the basis for saying, whoever you are, whatever setting in healthcare, these are the basic things that you should be doing at reviews. And it's not, apologies for the cliche, it's not rocket science, is it? And there is also potential there for a version of that to be patient-held.
And I would agree with that, and that was always what was intended, of course, in the National Outcome Strategy for COPD and asthma, which was about standardising all this information and the processes, but sadly that was not implemented to the degree that it might have been, so there wasn't any support for the standardisation mechanism. Actually, that's one of the possible uses for Respiratory Futures, because Respiratory Futures is a very good sort of centre for passing on the best practice in this area. So perhaps as a project we can look towards standardising a lot of this information that make it available, more widely available, in the absence of a specific network infrastructure.
And I think some versions are already there for discussion, aren't they? And certainly Primary Care Respiratory Society has resources that could be looked at, and British Thoracic Society, etc.
Certainly a post-exacerbation review is more likely to be effective, in my view, in primary care than it would be in secondary care, where it's often used to tick the box for a sort of contract or sequin type of approach.
Primary care has also the potential for ticking boxes in the QOF review, and I think that's probably an important side of the elements of a good review. Probably need to go beyond the basics that the QOF asks you to do in primary care.
Yeah, but I mean, things are moving on, aren't they? I mean, the QOF was 10 years ago, we thought that would stimulate quality, and actually the focus on quality and outcomes is completely different now than it was 10 years ago. So it's done its time, but we need to move on. I think we're coming to the end now, aren't we? So our time is up. Are there any more questions, Amy?
Well, we haven't got any more questions at the moment. I was going to suggest that anybody wants to send them through, please do in the next 5 minutes. But equally, you're welcome to post questions online on the Respiratory Futures debate area. We will pick them up later, and Stephen or Mike will answer them for the next 24 hours. So you've got another opportunity to get involved.
Okay, Stephen is just going to close up with a few comments, I think.
Yep, thanks, Mike. So my comments would be about patient involvement. I think there are now resources that can be used to drive standards upwards that can involve patients. For example, the British Lung Foundation 10 Steps to Best COPD Care Patient Passport. We'll have the slide up on the sort of final deck that goes on. But these are steps to best care that can be patient held, and I would encourage patients to approach their doctor, whether it's primary or secondary care, their nurse, whether it's primary, secondary, community care, and say, there's these standards that I've heard about. I'm not convinced I'm getting them all. What do I do about it? And that would be a very good way of driving up standards from the patient upwards. And I think from a professional's point of view, it's quite interesting. I mean, this has been a great discussion. Actually, I've really enjoyed, because what you really realise is how much common ground there is between what we're trying to do in various parts of the healthcare sectors, and how much it's all about a common goal of best practice.
I'd very much like to thank you both. It's been a fascinating half hour, and I think we've just scratched the surface. I feel we're going to get a lot more questions. I'd like to encourage people to also feedback via Respiratory Futures to suggest ways we can continue this conversation. I feel there's much more that we can do on this particular topic, and we're very open to looking at different ways of continuing this and discussing with Mike and Stephen. They're looking at me pale but enthused about ways in the future. So thank you all for logging in. Next month's webinar will have a focus on research, but if you log into the Respiratory Futures debate area later today, you can see both the PowerPoint deck and a recording of this webinar. Thanks very much.
Thank you.